Of course, Donna. You're popular. All right, can everyone hear us all right? Yeah, we got some nods. Perfect. I just want to ask everyone to please keep your microphones off until the end of the session when you can ask Donna your questions. I would like to acknowledge the traditional owners of the land on which we are on today, the Whadjuk Noongar people, and pay my respects to elders past and present. And I also just wanted to have a quick discussion. Congenital syphilis is quite a sensitive topic, so we just ask that people are just mindful of that and respectful when it comes to question times, and just sort of keep in mind that it is quite a confidential topic as well. Yeah? Yeah. Okay, I'll hand over to Donna. Thank you very much for your time and always sharing your knowledge with us. Let me just get your slides ready to go. Can everyone see the presentation? Yep, nods. Perfect. Okay.
So do you want me to drive that?
Yeah.
How do I change the slides? Just the up and down arrow?
Yeah. There we go. Us.
Oh, do you want me to move there?
If you want.
Okay. I can move anywhere. About that, but yeah. Okay, so good afternoon, everyone. And thanks for joining us with this congenital syphilis talk. So what I'm going to do today is to give you a bit of an overview of the notifications of congenital syphilis in Australia and WA, and then talk about the process of the review of the congenital syphilis cases. I know many of you have already been to one or more than one public health review of a congenital syphilis case, and some of you have even chaired them, and then others haven't had that opportunity yet. So I thought it would be useful to go through that with you, just so that you know what happens in that review. And then we'll talk about some of the public health responses so far, and you know, you'll know more about these responses than me because many of you are actually driving these responses. I'm deliberately not going to talk about individual cases because, as Rudy has said, it's quite a sensitive topic and there aren't many of them, or there's far more than what we want, but in total there are not that many, and so we really wouldn't want anyone to be able to be identified. So if you ask me for information like that and I don't give it, that is why. So congenital syphilis notifications in Australia and Western Australia. We can see from this graph that goes back to 2002 that WA was actually doing very, very well until very recently. So there were a lot more cases of congenital syphilis, you know, back in the early 2000s, but they were all in other jurisdictions in Australia, and we're actually keeping our mums and babies safe here. But in recent years, the increase in WA has been, you know, quite significant, and unfortunately, we are punching above our weight at the moment in terms of population numbers, you know, and the number of congenital syphilis cases that we're having in WA compared to, you know, what other jurisdictions are having. So that's not a good thing. If we have a look at what's happening with syphilis in females of childbearing age, and in pregnant females, I think that gives us a clue as to why there is so much congenital syphilis, because if you're getting syphilis in women of childbearing age and in pregnant women, then it's quite hard to keep congenital syphilis at bay. And what we need to do, you know, one of the things we need to do is to keep women of childbearing age and pregnant women safe so that they don't pass syphilis on to their babies. This was shown at the STI-BBV Quarterly Forum a couple of days ago, but I thought this is really interesting. So you can see there that this shows testing rates and notification rates and also test positivity rates. And you can see that for the metro, there was the testing's kind of gone up and down, but overall it's much the same. But if you look at the grey line, which is the test positivity rate, there was this bump in test positivity rate in the metro regions, and now it's kind of fallen away a bit. Whereas if you look at that grey line in the non-metro areas, the test positivity rate is just going up and up and up, and it's rising steeper than the rise in testing rate. So I think that's telling us that there's a hell of a lot more syphilis transmission going on in recent months in the rural and remote areas. And it lines up quite well also with our congenital syphilis cases, because we saw quite a few of them last year in non-Aboriginal people in the metro area, and this year what we've been seeing is congenital syphilis more in Aboriginal women and in the rural and remote areas. And this is just another graph. So what's I think useful to look at here is, if you look at that grey line again, you know, the total number of syphilis notifications in men and women, it's going up, and the increase in women is pretty much mirroring the increase sort of in total, and the bulk of that difference between the women and the grey line is men who have sex with men. But I suspect many of those men actually have sex with women as well. And don't worry about that decrease at the end. That's just because we haven't gone for a whole year to 2021. I suspect by the time we get to the end of this year, those lines will be further up that graph than what the scale is right now. So we'll move now to this process of the public health review of congenital syphilis cases. And if you want to have a look at the guidelines for what happens in this review, that they're on the Silver Book website. I think we're the only jurisdiction where for every congenital syphilis case, there is kind of like a set pro forma of what we will do as a public health review. That's not to say other jurisdictions don't do it. I'm sure they do, but it's not in, well, when I started writing this guideline, I asked every jurisdiction, what is your guideline for reviewing a congenital syphilis case at the public health level? And they said, oh, we don't have one. And then they would give me other things. I'm going, yeah, but that's not really what I'm looking for. So we have this set of guidelines, and they've been updated in the last probably 8 months or so since we've done a few more cases, and we will continue to update these guidelines, you know, so especially for those of you who have chaired cases or you've been involved in the reviews, you know, if you think that the guidelines can be improved in any way, you know, please let me know, and we can certainly, you know, consider all those improvements. So what happens? So the purpose is to review the public health management of a congenital syphilis case and to identify areas for health service improvement. It's not about apportioning blame, and it's really important that anyone involved in it knows it is not about apportioning blame. Through these reviews, we might find that there's a need to update relevant clinical and public health guidelines, and it also raises awareness and educates a broad range of people about syphilis, because, you know, at these reviews you would have people who are involved in quality and safety in hospitals, you'd have paediatricians, you know, so a wide range of people who may not come across syphilis in their day-to-day lives in the way that we do. So the process is that the Chief Health Officer, so that's Dr. Andy Robertson, he will be notified if there's a case of congenital syphilis, and then he will request a review to be done, and he will nominate a chair. And usually that chair for the public health review is the regional or metro public health physician in that PHU. And then the participants involve health and non-health providers who were in any way involved in managing the case, and may also involve health consumer agency representation. So, you know, if the case say if it's an Aboriginal person, or it may be a called person, and if the review participants don't encompass a body or a person who would be able to represent that case appropriately, we will find a health consumer to represent them to. And then we also have observers. So these are people who weren't involved actually in the public health or clinical management of the case, but who would have something important to contribute, so they can be observers. The preparation, so it's like cooking, especially Chinese cooking. All the preparation's done beforehand. And then when the thing actually happens, you toss it around or whatever, that only takes an hour and a bit, but all the preparation takes a long time beforehand. And the important thing about the preparation is the talking. So having done a couple of these myself, ringing up every person who was involved in managing that case, and so this will be obstetricians, paediatricians, social workers, GPs, midwives, everyone. It's really important, and I've put there, firstly, it's to get a detailed timeline of actually what happened with that woman and her baby, and when did she present to care, if she had any symptoms of STI, all that kind of stuff, which you're all really familiar with, and it's kind of obvious that you would need to know that as part of a review. But I think that the most important part of that process of ringing up everyone is that you are gaining their trust, so that by the time they come to the review, they trust that you're not going to hang them out to dry, is not about apportioning blame. And because they know what the process is and they trust you, they are then going to trust everyone else who's sitting around that table, so that we can talk openly and honestly about what happened, perhaps what should have happened, and then how do we improve from here. And the feedback that I've had from especially people who normally live in the clinical world is that they came to one of these reviews and they said, oh, this is actually really nice. We didn't want to come to start off with, but it's not like the other reviews that we do. And I thought, good. Well, I mean, not good in the, all reviews of quality and safety things should be pleasant, and they should be about improving things, but they said that this was really different. So that's probably, a bit of a tick for public health people in the way that we do business. The relevant public health unit prepares an EPI update, and that sort of sets the scene at the beginning of the meeting. And then everyone signs confidentiality agreements. And, even though we all work for the health department and we've all signed a confidentiality agreement, this is an extra thing. But we would also have people who work in general practice or private clinics or, say for Department for Communities. And so they haven't signed the health department confidentiality agreement, so they need to sign that agreement too. Then at the review, we start off with the case presentation, and what I've found is that no matter how beautifully you've done all that work to get a detailed timeline of what the woman and her baby have what care they've had, inevitably something new will come up and someone says, oh yes, but you didn't talk about that. So that's fine. We go through that whole case and get a really accurate timeline of what happened. And having done most of the work beforehand means that you don't have to laboriously spend, an hour getting this timeline, which you might spend if you haven't done the homework before. And then we have the EPI update. And then the rest of it really is looking at, well, okay, let's see what actually happened, the messiness of real life, versus what the guidelines say should have happened. So we think about the antenatal care, syphilis testing in pregnancy, how long was it between the mother being diagnosed and her being treated for syphilis? Did she get the right clinical treatment? You would hope so, because it's not like there's a lot of choices for treating pregnant women with syphilis. There's one antibiotic. Then there's the contact tracing. and the follow-up of the woman. And then with the baby, there's, you know, when did the baby get diagnosed? And unfortunately, you know, the diagnosis is not always that prompt. So we have had cases where it's been some time before the baby's been diagnosed. Babies born with congenital syphilis are infectious in and of themselves. You know, their secretions have got spirochetes in them. So we need to think about infection prevention and control at a health service level. And are the staff familiar with that? Because although we should always be practicing universal precautions, it may well be that they didn't think the baby was infectious. And then, you know, follow up of the baby. And, you know, these babies, often they're born very sick. They have quite long, protracted admissions to neonatal ICU, and a lot of follow-up for things which are really nothing to do with syphilis. You know, learning, you know, just their overall well-being is really important. So then we, you know, make some conclusions about, well, you know, what care was delivered that was in accordance with the guidelines, what was not in accordance with the guidelines, how could things have been improved? Was it preventable? Is a separate clinical incident review required? And I think almost inevitably it is. Sometimes it's been done before our public health review, and other times it needs the public health review with the safety and quality representative who's part of that review, you know, to then initiate it at their health service. And then what sort of recommendations would the review group want to make at the local, state and national levels? And the reviews, just to let you know that they are recorded. You know, it's the wonderful thing about doing stuff by VC these days. You know, you can record them and then a transcript is made. And I think what we're going to do now is, rather than have a set of minutes that sort of goes on this long, is we will have a normal set of minutes, but we can have the actual verbatim transcript attached to that as an appendix, in case anyone, you know, queries anything in the future. Because after the transcript's been, you know, put into words and written, we would delete that audio file. We're not keeping that forever. Okay, so I said that I wouldn't talk about individual cases because of the confidentiality and sensitivities involved. But what I feel that I can share with you is that of the cases where I've either chaired the review or been an observer in the review, these are the two main themes that come out, and they usually come out in different women. So there'll be a group of women where you go through the whole review and it's quite clear, everyone can see, well, she presented at that time, but for some reason she didn't get tested for syphilis, even though she had chronic headaches and fever, okay, which is not typical of syphilis, but we all do know that that is one of the, you know, they are some of the symptoms of secondary syphilis. Or it could be, yeah, she actually did come for antenatal care at around about 30 weeks. No one thought to ask her whether she needed a syphilis test or to offer her a syphilis test. So there's that group of women who, if we'd actually done the testing in accordance with the guidelines, and if the antenatal care staff who saw her had talked about sexual risk and partner change and perhaps drug and alcohol use, domestic violence, had talked about it at that time, someone would have tweaked, yeah, I think you're probably at high risk of STIs, so we probably need to test for STIs, even if it's more frequently than what it says in the guidelines. And through doing those reviews of that group of women, you know, we have in recent months changed the syphilis in pregnancy testing guidelines to include 3 tests for all women in WA, and quite different to what any of the other jurisdictions have. Then there's the other group of women And I think these are the group of women who really challenge us as health practitioners and challenge the health system, not because they're doing anything wrong, but it's because what we are offering or what they perceive we are offering is not what they want, and it's not meeting their needs. So these are women who haven't engaged in care. So they might be homeless, they might be using drugs, they might be highly mobile, moving from one region to another. They may be actively concealing their pregnancy for a variety of reasons, which we probably don't even begin to understand the first bit about. But for whatever reason, they're not engaged in any sort of care, let alone antenatal care. And so they're the ones that, you know, we could be testing the women who come to our clinics every week. We're not going to get these women. And I think this is the big challenge for us. So I recently heard a news story on Radio National, and I went and dug up the paper that the news story was about. So it's a paper in Lancet Global Health, and it's called Effective Birthing on Country Service Redesign on Maternal and Neonatal Health Outcomes for First Nations Australians. So this model of care, it's called birthing in community, and it was done in urban Queensland, and they recruited mothers who had, and in particular Aboriginal mothers, to deliver a lot of the antenatal care and to provide that wraparound support around a woman and her family when she's pregnant. And what they were able to do, which I think is quite remarkable, is they were able to reduce preterm birth rates, which we know in Aboriginal women tend to be much higher than that for non-Aboriginal women. They actually reduced preterm birth rates in these Aboriginal women who were part of their study to below the baseline preterm birth rate for all women living in that area. And they did that through essentially engaging women in care and providing them with the health and I guess the non-health, but all those other services that they needed. And they did it in such a way that the women could, you know, even though it was an urban area, but they were able to get that care within their local community. So I think with this group of women who are delivering babies with congenital syphilis because they're just not engaging in care at all, it's really putting a challenge out to us about how do we redesign antenatal care. And I think what we're seeing through our STI syphilis public health lens is probably part of a bigger problem. If we were working in drug and alcohol services, we'd probably be seeing these as babies born with FASD. If we were working in diabetes education, we would be seeing this as, you know, babies being born to mothers who have diabetes and have had diabetes very poorly controlled, so the baby ends up with a lot of complications. To me, it's really part of a much bigger issue in antenatal care, and especially for those of us who are working in rural and remote areas. A lot of this speaks to the reducing, you know, forever reducing number of opportunities for women to get care and to deliver on country where they are surrounded by community, their family, and where they feel comfortable. And, you know, I often wonder, I'm, coming to it from the end of a doctor, having done a DIPOBS many years ago, how much do we trade safety and our measures of safety, which are maternal deaths, perinatal deaths, how much do we trade that for outcomes that patients would measure and would think of as important? And there's this, I think, growing recognition within the health services sector that we need to measure not only the outcomes that we're interested in, those really what we would call pointy end outcomes, like what was the APGAR, what was the maternal mortality rate, but we need to be thinking about patient reported outcome measures, so things that patients are interested in. And I'm not saying that they're not interested in death. Of course they're interested in death. They don't want to die when they're giving birth, but they also value being on country. They value having their partners or their loved ones, in the birth room with them. And, we've seen, very recently with COVID, women, Aboriginal and non-Aboriginal, having to be in King Edward by themselves because they weren't allowed any visitors, to protect everyone from COVID. And if you're in there by yourself, your baby's in NICU and you're not getting any visitors, what is that doing to your mental health? And how do you then pass that stress through to your family? I just don't know. I'm not saying these are easy questions to answer, but I think they're things that we need to think about. So for me, being involved in these cases of congenital syphilis reviews has really made me think far more broadly about antenatal and maternal care and what part we can, as people involved in STIs, disease control and public health, what part can we play in advocating for care that is more responsive to people's needs? Okay, so might move now on to something that's a bit more positive. So, what are we doing? What are we planning? Rather than the woes of how bad our healthcare system is. Okay, so what's happening in terms of prevention and education? So the way I've kind of structured these slides is the things that are in blue are things that are to come, which are in the pipeline, and the things that are in black are the things that have already happened. So many of you will already have seen the Healthy Sexual campaign. If you're in the right demographic group, which I clearly am not because way too old, you may even have seen it in your social media feeds. So that's the Healthy Sexual campaign, and we've got a whole section on that, to do with pregnant women and antenatal care. And we're working with ARQA on a Aboriginal specific antenatal campaign, and also including information about syphilis and congenital syphilis in the flip chart and the syphilis brochure. Workforce development. So the ASHA modules for syphilis and for STIs are already on the ASHA website. They're free. They've got, CPD points for doctors and for nurses and midwives already. It's built in. And the midwife-specific syphilis module is in development as we speak. So I think be what, a few months, Rudy?
I'm not sure we're up to that one.
Don't know. Well, it's been going for a few months, so I definitely think before the end of this year.
Yes.
Yeah. Testing, diagnosis and treatment. We've moved STI screening recommendations for pregnant women to the front part of the Silver Book. So it's in your face. You can see it's in your face in text and also with a picture in case you missed it. We're constantly updating that section. I actually had a look at it today and I realised probably the most recent updates haven't translated onto the page yet, but they're not too far off the mark. The testing intervals are correct. We just need to tweak some of the words about what specimens to take. But you guys know what specimens to take, so I don't think it would bother you. And we've been writing to custodians of national and other state guidelines to tell them about what we're doing. And what we would like national guidelines to say is that where you have a local or state guideline, you could follow that if it recommends testing that is more frequent. And of course, we've got the WA syphilis point of care testing program that's been rolled out. And Matt, do you want to give people an update about that? And any more new sites? No, he's keeping very quiet.
No, it'll be, there's like meetings.
Okay.
Over the next 2 weeks.
Yeah.
That people get sick of it.
Okay, yeah. Okay, then we've got surveillance and reporting. So we're including information about congenital syphilis in our WASOR communiques. we've got stalk data turned on now. So in WACS, all the WACS sites now, I think, have the ability to record antenatal testing at booking, at 28 weeks, 36 weeks, and also it's optional, but the testing at birth and 6 weeks and referral for 6 weeks testing postpartum, that's all been enabled in stalk for the WACS regions. And then enhanced syphilis surveillance for quite some time now has included information about pregnancy. And we're also going to update our quarterly reports so that they have a section specifically about congenital syphilis and syphilis testing in syphilis rates and syphilis notifications in women of childbearing age and pregnant women. Okay, so in the policy space, well, we've got these public health and clinical reviews. The WASORG is constantly updated about syphilis in pregnant women and congenital syphilis cases. Syphilis-specific positions in regional ARCHES are being set up. Siren is doing some research on barriers and facilitators for Aboriginal women to engage in antenatal care services. There's advocacy going on with the Health Insurance Act to allow RNs and Aboriginal health practitioners to do STI testing without having to use a doctor's provider number. And there's also advocacy going on at the national level. There are some Medicare item numbers which GPs and obstetricians can claim. And at the moment, those item numbers say that at certain stages of the pregnancy, you should be asking about domestic violence and mental health. And we've said to the MBS that they should put in their STI risk assessment as well, because, you know, these things are often very intertwined. And if the doctor or obstetrician is sufficiently skilled to ask someone about domestic violence and mental health, they should also have the same skills to ask them about an STI risk assessment and offer testing if that's required. So that is the end of my presentation. And I'm quite happy to take questions or any comments, because, you know, I know many of you work in this space and there may be things that you're doing that I haven't mentioned, which are, you know, aimed at reducing syphilis in pregnant women and their babies. So we'd love to hear from you.
Can I say something?
Yeah, please. Yeah. Who is it?
Sorry, it's Sunny from Aqua.
Oh, hi, Sunny. How are you?
I'm a bit crook, so sorry if I'm even less succinct than usual. But I just wanted to say, you were talking about the risk factors of the women who had syphilis and weren't tested for it when they presented. And I think they presented late. But, you know, we don't look at risk factors for women. You know, are you a vegetarian? Then I'll test for your iron. Do you have a family history of diabetes, or are you thirsty lately? You know, I'll test for diabetes, because we know that low iron and diabetes are detrimental to the fetus. We just automatically test all people for that. And so I think that obviously it's all the more important when you have someone that has symptoms, you know, to check or recheck. But the fact that the women came and they were pregnant means, you know, they should have been tested for syphilis regardless of any risk factors, because they might be in a monogamous relationship as far as they know, or maybe they are, but someone had syphilis before they got together, or, you know, you can't, you know, obviously, yeah, I just think, I know we've all been in a situation where we could have done a better job and some things fall through the cracks and it's terrible. So I'm not blaming anyone, but I would just implore all the staff that I work with or have worked with, you know, it's not an opt-in or opt-out or something to keep in the back of your mind. It's something that has to be at the forefront and done for everybody, given the catastrophic outcomes if we don't do it.
Absolutely. Look, I think that's very true, Sunny, and that's why we have increased our routine syphilis testing in WA now to booking 28 weeks and 36 weeks for all women across the board, regardless of what the risk assessment shows. However, I do think that it's important that for some women, they may need even more frequent testing. And what we wouldn't want to happen is for a woman to say, oh, well, I was tested then, but actually now I've got some symptoms, but because I had a negative test then, I don't really need to do anything. So we just sort of need to keep in tune with that. Or if a woman, say, changes partners during her pregnancy in between one of those testing intervals, that she needs to be provided with the information so that she knows it's important to tell us, because if she tells us, we would offer her an additional test, say between the booking test and the 28-week test or whatever.
Yeah, I totally agree. I mean, I thought you were saying that the other people had risk factors and had not been tested at all. Did they were not tested at all, or they just hadn't been tested extra?
No, look, I can't go into individual cases, but there were women who did front up for testing, and if they had been tested at the recommended intervals, we probably would have picked it up. There were also women who attended for antenatal care and did have symptoms which, you know, they may not have been so obvious of an STI, like, oh, I've got a chancre, but, you know, they were symptoms of syphilis, and we know that syphilis presents with many different symptoms, and it was not thought, perhaps because you've presented with that symptom, we should test you for STIs. And so I think, you know, it just requires everyone to have more of an awareness that, you know, people are presenting with symptoms, or, you know, and just asking, you know, about, how is your partner? And perhaps that would say to, you know, that might give someone the reason to say, oh, well, I actually changed partners since you last saw me. Then we could, you know, in a very non-threatening way say, oh, well, how about we do some STI screens for you?
Yeah, I agree. And I mean, there's routine testing for iron during pregnancy, but if someone says, I'm just really feeling washed out and weak and whatever, they just test again. You know, we absolutely have to do what they're saying, especially given the outbreak. And I mean, I agree. It's easier in smaller communities because we know the people well, but we just always go, how's things at home? How's he treating you? You know, do you have any concerns and that sort of thing? So I agree, it's got to be an ongoing thing. And I think if you tell women, you know, there's a syphilis outbreak and these are the things that may put you at risk, and if you're ever worried, we're absolutely happy to test you more. You know, it's just to keep the baby safe because it's such a bad outcome. It's not, I think just normalising it.
Yeah, it's all part of that educating women. And okay, so I'm just having a look at some of the comments in the chat. And Francine has said cultural security in action, referring to the Lancet article. Absolutely, Francine. It's a beautiful example of that. Once someone tests positive, I'm a midwife, how do we approach them and tell them the result? Is this a straight obstetric review or GP obstetrician? Great question. I might actually throw that out to someone who actually has done this recently, because I tell many people they have syphilis, but they're gay men at the M clinic, so they're actually far more expecting me to tell them that they've got syphilis. Is there anyone who's with us who has had to tell a pregnant woman, or any woman for that matter, recently that she's got syphilis when she wasn't expecting it, and could share with us how you do that?
It's Heather here.
Okay, thanks, Heather.
Hi, Donna. I was just going to bring up, before I answer that question, that one of the recent ones that we've had is that they had the tests at the right intervals, but the interval, well, the right according to the program at the moment, but the interval between 28 weeks and 36 weeks is awfully long. It seems to be, in our experience, a risky time, those 2 months. And in our most recent one, there was a history of having had an STI in the past, and we discussed at our review that that was a prompter that maybe she should have had a more frequent screen. So in other words, monthly, 28, 32, 36 weeks, which would have picked it up. Now, as far as we tell patients, it's like any STI, you know, you just sit down and say we found an infection, and this is one that we need to treat because we want to ensure that the baby is fine and you're fine. It's very easily treated. It just needs an injection of penicillin. But we will need to, having discussed if they have a regular partner or there's a partner at the moment, we will need to look at your partner and see whether your partner has this infection as well, because we have to treat the two of you together. And we also need to ask you about your partners in this past, it depends on their RPR as to when we think they got it, in the past few months. So it's usually pretty straightforward. There's most people are very glad to get treated as soon as they can once they know they're infected, and they certainly want to protect the baby. And you then are answering their questions about it after that.
Thanks, Heather. And I think that, look, if anyone is in the situation where they've not done this before, and, this is the first pregnant lady that I've seen who's got syphilis, on the Silver Book, there's a link to the King Edward guidelines for treating pregnant women with syphilis. And you can always ring up Michelle Porter at King Edward. She's a great resource to go to. And if the obstetrician or GP that you're working with hasn't dealt with this before and they're a bit nervous, so they can always ring up Michelle. They can also ring up the public health physician at your local public health unit, because many of our public health physicians have dealt with cases of congenital syphilis, or syphilis in women of childbearing age before. And so although they're not all clinically trained, and they're not sexual health physicians like Heather, but they would definitely know how to point you in the right direction. And often the doctor just wants to have a chat to another doctor, so they're there as a resource. And then for the paediatricians, there is also a link in the Silver Book to the Child and Adolescent Health Service guidelines for treating babies with congenital syphilis. And again, there are infectious diseases physicians in PCH who are pretty well across this and happy to help anyone across WA if they want to talk about, how do you treat this baby, how do you deliver this baby. So I think probably my message for that question is reassure the person, the doctor that you're dealing with, that it's absolutely fine to reach out for help and to show them the guidelines, because they may not know where the guidelines are. They're not all as familiar with the Silver Book as we are.
I think, Naomi, did you have a question for Donna or a comment?
Yes.
That you had your hand up.
So,
Hi,
hi, how are you?
Good.
I was just wondering if we can expand more on the health promotion side that ACWA's doing, or any other future plans anyone might have.
Yeah, please talk about it.
Sunny, would you know much more about what the ACWA is planning on doing with this and syphilis in general? Because I know the Department of Health just brought out their Healthy Sexual campaign, but there's no, especially in Metro, I'm not sure what the country, the WACs are doing, but there's no real health promotion in targeting the syphilis outbreak, even to let community know that, it is out and about to get tested. And what we're finding as well is that some doctors, if they don't have a chancre or signs of it, they won't test unless you request. So
those are great questions and great points. So I also have a lot of concerns about, I know a lot is being done in regards to health professionals, a lot of information getting out to them, and specialists in the field yarning with, EDs and clinics and, ASHM training and that sort of thing. But I don't feel like there's a lot happening, passing on the information to the youths who are at risk. So it was a lot easier when I worked in a remote community. I could just literally go around and talk to 1,000 people that lived in the 3 communities, and mums and dads and men and women and children of all ages and high-risk people. And I do think that we need to do more in that space. A lot of the youths that we've hired on ACWA, I've been quite alarmed to see the Aboriginal youths have no knowledge of the syphilis outbreak, and when they talk to their friends after I talk to them, they have no knowledge. So I think that we're overall not doing well enough in that area. I know Aqua Yep has done a lot of promotion in the area, and we're working on some campaigns. We're just trying to put together, paperwork and expression of interest forms and decide on money and that sort of thing. But we have a few different things in the pipeline that we're furiously working on behind the scenes. One of them is what the wax flip chart, which was mentioned. So I've only been at Aqua for, I think, 7 months now or something like that. So I'm not on top of everything, with all the syphilis outbreak meetings alone. I'm surprised to get anything else done, but we're creating a flip chart that we're going to be able to disseminate to services that people can use to have a yarn with patients, that will have pictures that will help explain the risks, the impact on pregnancy, how you get tested, where you can go, that sort of thing. We're still in the draft stages for that, so we're not at a point where we're going to put it out to people for feedback, but we're happy to do that when we get there. Another one is a social media campaign. So we've created a social media group on Facebook, but our youth officer resigned, and we were trying to get them to lead it because obviously Veronica and I have had a lot of experience in our field, but neither of us are young Aboriginal people. We're going to do a campaign where we have a PlayStation 5 available and other prizes, and we want youths to watch a syphilis video clip and then submit memes or posters or ideas or anything like that to promote any health messages that they get from the syphilis video about the importance of testing, the fact that you might not have symptoms, and anything at all. We're hoping to get that up and running soon. We're also looking at offering grants out to the regions, probably for a small amount of money. Maybe we'll team up with NATO for people to have a cook up and a yarn with some prizes to chat to people about syphilis and the concerns of congenital syphilis. And then we're not sure then if people want to incentivize testing for hard to risk youths, like fellas at footy that haven't been tested in a couple of years, or if they want to try and come up with ideas for health promotion materials that they put back to Aqua that we can help them design. And what was the other thing? We're working with the Department of Health as well on the congenital syphilis campaign, trying to get, have a look about what health promotion materials we can have to put out. Is that it, Veronica, or have I covered it? I don't know what else. I'm firing on not many cylinders at the moment. Veronica, that's you.
Yeah, that's me. Yeah. No, I think you covered it all. That sounds good. We're really sort of we realise that things need to try and move quickly, but I guess it's about really engaging on that community level about what's going to work in community. So we thought the grants were a good idea to actually allow each community to do what they felt was the best way to get the message out there, as well as the flip chart, which we thought would be really helpful for people working in clinical services, but also could be used for people working with any youth, like youth workers, Headspace, like other organisations where they might be able to have that yarn with young people about syphilis, because it is really surprising about the fact that a lot of young people don't even know that syphilis is a concern. Yeah. Yeah.
And so with some of these things we started when I first started at Aqua, but in amongst all the other commitments we have, and I have ideas, Veronica and I have ideas and things we can chat about, but we don't know the legal issues with copyright, with pictures we want to put in the flip chart, and, forming the documents to put out the grant money, all that sort of stuff. So it's a steep learning curve for us, but we do have a few ideas that we're working on, and hopefully we can start putting these things out to services and communities soon.
Thanks very much, Sunny and Veronica, and thank you, Naomi, for asking the question.
Just to also a really quick update, as part of the Metropolitan response, we do have a newly established Metropolitan Prevention, Education and Community Engagement Working Group that's only met once, but it is something that the group will be doing, is sort of mapping what is out there and looking at those gaps and kind of coming up with some strategies moving forward. So the sector will be kept up to date on the progress of that.
And there has also been some discussions around working particularly with the street present homeless population, around how and what avenues are going to be the most appropriate to do some education for that space as well, to try and address quite a nuanced group, a priority population, sorry. So yeah, there is quite a fair bit in the pipeline in relation to prevention education. And then there were the 3 campaigns that were done all in the metro last year as well, since April last year. So there have been quite a few campaigns, but yeah, there is still space to do more.
So I think we might end the session there, Donna, if that's all right with you. We've gone a little bit over time, apologies for that. But if you have any further questions, please feel free to reach out to myself and or Donna, and we will try to assist you best we can.
Thanks very much, everyone.
Thanks, Donna. That was really informative and really great.
Thank you.
Thanks, Donna.
And for those who I saw your faces, Keely, Heather, those in Derby, it's great to see you.
Thanks, everyone. The recording will be uploaded to the website as soon as we can.
I'm just seeing your beautiful face, Veronica.
Thanks. It was great, Donna.
Thank you.
Thank you.